Let us discuss anesthesia implications of liver transplant surgery. Our side headings would be concerns, etiology, stages of surgery, equipment, intra-op complications, post-op complications, and care. Okay. Coming to concerns, here liver is already affected, so it will take all other organs with it, like the CVS system is affected in the form of systolic and diastolic dysfunction. There might be decreased BP, increased cardiac output. Coming to CNS, the patient might be in hepatic encephalopathy or cerebral edema. So we have to diagnose and prevent those. Coming to respiratory system, there might be hepatopulmonary syndrome or portopulmonary hypertension, hepatic hydrothorax, and due to massive ascites, there might be atelectasis and decreased FRC. So during pre-oxygenation, we have to be careful so that because in these patients, there might be rapid desaturation. So we have to adequately pre-oxygenate the patient. So coming to etiology, in what situations you'll go to liver transplant are mainly cirrhosis, malignancy, and liver failure. Okay, acute liver failure. Coming to stages of surgery, this is important because all your complications or equipment needed will be depending on these stages. Firstly, dissection phase and hepatic phase and neohepatic phase. These are the stages of surgery. First dissection phase, that means they will dissect the native liver and IVC. First they'll open the abdomen, the ascitic decompression might occur, and next they'll dissect the liver from its attachments. So what are my concerns in these phase? Because of sudden decompression of the ascitic fluid, there will be hemodynamic instability. Added to this, if there is hemorrhage during dissection, again there will be hemodynamic instability. That means my concerns will be hemorrhage and hemodynamic instability. Okay, coming to anhepatic phase. Here that means it is similar to there is no liver in the body right now. So whatever the coagulopathy is there, it worsens now. The acidosis worsens. There won't be any gluconeogenesis. So the patient is more prone for hypoglycemia. There will be hypocalcemia and also hyperfibrinolysis. So depending on these complications, I'll be treating the patient with calcium or I'll measure the glucose levels and I have to supplement the glucose. For hyperfibrinolysis, I have to give antifibrinolytics like tranexamic acid and I have to prevent further worsening of acidosis, right? Coming to neohepatic phase, that means we are keeping the new liver in the body. So, the liver, the donor liver is preserved in a solution like University of Wisconsin and it is perfused with that fluid. And when we keep that liver into the patient, there will be sudden release of that fluid which contains H plus, K plus and vasoactive substances. So there will be sudden increase in preload and also there will be hypotension, right heart failure and if it prolongs there might be arrest also. So I have to be very careful and that is called as reperfusion syndrome. So I'll treat with prophylactic calcium and soda bicarb and I have to treat the hypotension with fluid resuscitation and vasopressors, right? So the second complication is ischemia reperfusion. That means ischemia means there is something problem with the graft, right? So why there is problem? Because of endothelium dysfunction. So there is no proper reperfusion that because of endothelial dysfunction and there is ischemia and graft dysfunction. And the third thing is increased bleeding. Why there is increased bleeding? We have already kept a new liver. So why should be there any bleeding? Because the new liver takes time to produce the new clotting factors. That is one reason. And the second thing, the already present platelets will be sequestered in this new liver. And that is the second thing. And there will be release of heparin-like substances which may increase the bleeding. So we can give protein for that. That is the third one. And there will be increased hyperfibrinolysis which has started before. So we have to give antifibrinolytics. So these are the causes for increased bleeding during the neohepatic phase. So these are about the stages of surgery and the complications in those stages. Coming to equipment, so please remember three things. There will be electrolyte and acid-base disturbances, there will be hemorrhage, and there will be hemodynamic instability. So depending on that, we need our equipment. Okay, we'll see it later. And coming to intra-op complications, same. We have already read it. So there will be hemorrhage, metabolic and electrolyte disturbances, and we have to maintain we have to prevent hypothermia. We have to maintain a normothermia because hypothermia increases the bleeding. We have to maintain adequate cerebral perfusion pressure in those patients. Otherwise, the complications will increase, right? And coming to post-operation or post-operative complications and care, we will discuss in detail. So, my concerns for liver transplant is already the liver is in failure. And along with that, there will be added intra-op derangements. Okay. Coming to etiology, cirrhosis, the causes of cirrhosis might be metabolic or viral or cholestasis, drugs and toxins, and outflow obstruction. Okay, the second is malignancy. Here we have two criteria, Milan and San Francisco. So you have to remember some numbers here. For Milan, it's 5.3, and for San Francisco, you have to add 1.5. That means 6.5 and 4.5. So what is this number? In Milan criteria, it says that the single tumor has to be less than 5 centimeter or up to 3 tumors, none greater than 3 centimeter. Okay. In the San Francisco, the same thing, but the numbers change. It says single lesion less than or equal to 6.5 or 3 tumors, none greater than 4.5. Okay. And in these two criteria, there shouldn't be any extrahepatic spread. Okay. No extrahepatic spread. Coming to the third cause, acute liver failure. This is again divided into PCM induced and non-PCM induced according to King's College Hospital prognostic criteria. Let us see that. So PCM induced, the criteria include pH less than 7.3 and presence of three factors which are PP greater than 100, grade 3 or 4 encephalopathy, and serum creatinine greater than 3.4 mg per dl. Okay. Coming to non-PCM, here it is irrespective of grade of hepatic encephalopathy. The criteria include PT greater than 100 seconds or presence of any three among the following, which includes PT greater than 50 seconds. See, here it is 100, but here it is 50. Okay. And jaundice to encephalopathy time, irrespective of the grade, okay, just encephalopathy. Jaundice to encephalopathy time is greater than 7 days. Serum bilirubin is greater than 17.5 mg per dl, and the cause has to be non-A, non-B or drug or halogen induced fulminant hepatic failure. And the age should be less than 10 years or greater than 40 years. So what are my concerns? This we have already discussed. That means in CVS there will be vasodilation, increased cardiac output and cardiomyopathy. So I have to have a thorough cardiac evaluation, ECG and echo are so much mandatory. And if the cause is amyloidosis, I have to have a pre-op pacemaker insertion. Okay. Coming to respiratory system, the patient might have hepatopulmonary syndrome, respiratory alkalosis, pulmonary hypertension, restrictive lung pattern, hypoxia, and hepatic hydrothorax. So I have to have chest X-ray, PFTs. Okay. And if there is pulmonary hypertension, we have to go for pulmonary artery catheterization studies. So renal, there might be oliguria or tubular necrosis because bilirubin is directly toxic to tubules and the patient might land into hepatorenal syndrome and we have to prevent it and treat it accordingly. So obviously there will be hemostasis alteration. So altered hemostasis, anemia, thrombocytopenia, and there are decreased clotting factors. So we have to keep blood and blood products ready and we have to have a baseline TEG or rota. Coming to electrolyte abnormalities, there might be hyponatremia, hypokalemia, hypomagnesemia, and hyponatremia is very much important because it is an important factor for graft function and recovery, and its correction should be in a gradual manner because sudden and fast correction might lead in central point myelinolysis. So CNS, there might be encephalopathy and cerebral edema. We have to examine the patient for its presence and we have to grade it. We have to prevent it first, and if it is already present, we have to treat it accordingly. Coming to actual liver, we have to know the actual etiology based on the imaging study so that I have to manage my drug doses according to it. So other manifestations might be the patient will be malnourished. So he is more prone for infections. His muscle mass is less. So there will be respiratory muscle insufficiency in these patients. And if there is a history of esophageal varices, we have to ask the patient whether sclerotherapy was done, how was the varices treated, what is the present position of the varices. Okay. And also we have to see for any psychiatric issues because these patients will be alcohol dependent drug addicts, right? So we have to differentiate between hepatic encephalopathy and the psychiatric issues. And we have to screen for other malignancies. Okay. So what are the contraindications for your transplant? Overwhelming sepsis, refractory hypotension, acquired immunodeficiency syndrome, and uncontrolled intracranial hemorrhage with permanent neurological damage. So, equipment. Just remember three things we have decided now: hemorrhage, hemodynamic instability, metabolic, and electrolyte disturbances. Right? So, there will be hemorrhage. So, first I have to prevent the hemorrhage. So, I have to maintain normothermia. Right? So, I need fluid warming devices. Done. So, I have to know the cause. So, I have to have a tech. Now there is bleeding. So I have to infuse blood and blood products or the fluid, whatever might be necessary, right? So I need syringe and infusion pumps for that and blood products. Okay, now because there is a massive hemorrhage, I need to go for auto transfusion. There has to be cell saver. And if necessary to decrease the bleeding, to decrease the hemodynamic stability, especially, I have to have the veno-venous bypass machine. So this is regarding the hemorrhage. So there is hemodynamic instability. I have to know whether what is the cardiac status. So I have to have transesophageal echo and multi-parameter monitoring for it. So done. And for these derailments, I have to have ABG and electrolyte machines, right? And apart from all this, these are the routine things which we have to have almost for every surgery. Anesthetic drugs, routine, and also the emergency drugs and the drugs needed for electrolyte disturbances. Okay? And these electrolyte disturbances may in turn cause arrhythmia, so I have to have anti-arrhythmics also. So if you remember, no need to buy heart individually. If you remember the problem, you can easily know the equipment necessary. So obviously, we'll go for a general anesthesia, but this is a liver disease patient, right? What are my concerns? I have to adjust my drug doses because metabolism is affected in liver disease patients, and there will be altered pharmacokinetics and pharmacodynamics. I have to decrease the dose or increase the dosing interval because depending on the extraction ratio. All that we'll be discussing in anesthesia for liver disease. Okay. So, as of now, we'll give pre-medication, induction, and if there is increased intra-abdominal pressure, will be going for RSI and intubation, and maintenance will be with fentanyl, right? For neuromuscular blocking agent, we'll generally prefer ethacurium or cisatracurium because vecuronium is less metabolized and action will be prolonged. But in prolonged cases, and if we have a neuromuscular monitoring, some might use VEC infusion and then lesser doses based on neuromuscular monitoring. Okay? We'll be avoiding N2O because of air embolism. Done. So procedure same depending on the equipment or the things we do. So we have to infuse. So we need a central venous catheter and large bore IV cannulas. We have to have a thorough monitoring about the BP. So I need an intra-arterial catheter and cardiac output monitoring. The rest, urinary catheter, temperature probe, nasogastric tube decompression and warming devices and adequate padding has to be done. So procedure per se, which we have already discussed, it includes firstly dissection phase in this native liver and its attachments are dissected. IVC is mobilized and branches ligated. My problem here is hemorrhage and hemodynamic instability. So apart from managing that, I have to monitor blood glucose levels and I have to check for cardiac filling pressures. The second is anhepatic phase. The IVC is clamped and the liver is removed. So total it is like no liver in the body. So there will be worsening coagulopathy, absent citrate and lactate metabolism, which worsens again the acidosis. There will be decreased gluconeogenesis and there will be worsening hypocalcemia and hyperfibrinolysis will be there. So we'll be treating according to it by giving antifibrinolytics, FFPs, calcium, and we have to prevent further acidosis. So I'll get ready for the next stage now. So next stage is neohepatic phase. So I'll be keeping a new liver. So I have to give a prophylactic methylprednisolone almost 10 mg per kg to protect the graft against dysfunction. Coming to neohepatic phase, in this we are keeping the new liver to the patient, right? So there will be a donor liver which is perfused with colloid or crystalloid so that there will be flushing out of air and metabolic products. Okay. So then we'll do the anastomosis between donor hepatic vein to the recipient's IVC. After this, other vascular anastomosis will occur. The preservation solution used will be most commonly University of Wisconsin. Okay. So what will be our complications? Expected complications would be reperfusion syndrome, which means there is fall in systemic mean blood pressure by greater than 30%, and this fall should persist for at least 1 minute, and this should occur in the first 5 minutes. Okay, so this is reperfusion syndrome. Why this is occurring is due to the release of cold acidotic hyperkalemic solution. So acidotic, that means there will be increase in hydrogen ions. Hyperkalemic, that means increase in potassium and vasoactive substances, right? So this will cause hypotension, right heart failure, arrhythmias and cardiac arrest. So according to these complications, we'll be treating that. So we'll be giving prophylactic calcium and soda bicarb and fluid resuscitation and vasopressor agents to maintain the blood pressure, and we have to correct electrolyte abnormalities including hyperkalemia, that is increase in potassium, and hypocalcemia. So the second one is ischemic reperfusion injury. Ischemia means there is something problem with the organ, right? So here the organ is the graft. So there is impaired reperfusion of the graft leading to graft dysfunction due to endothelial dysfunction. Okay. So this is due to endothelial dysfunction, and reperfusion injury is due to cold acidotic hyperkalemic fluid entering into IVC. Coming to pronounced bleeding tendency, we have kept the new liver already, right? But still there might be increased bleeding because the new liver takes time to produce the coagulant factors, right? So that is one reason. The other is the already present platelets might be entrapped and sequestered in the new liver. That is the second reason. There will be hyperfibrinolysis. That is the third reason. And there will be release of heparin-like substances from the new liver. That has to be treated with protamine if needed. So these are the four reasons why there will be increased bleeding even after neohepatic phase. So if the graft is functioning good, there should be on-table production of bile, and serum lactate has to go in a downtrend manner, and the calcium should come back to normal, and the serious instability should be normalized. So all these are the signs for good graft functioning. If these are not seen and there is still increased bleeding, that means that is graft dysfunction. Okay. So what are the complications? Firstly, blood loss. So for this blood loss, I have to manage fluid and I have to give blood and blood products accordingly. Coming to fluid management, until hepatic transaction, it should be restrictive. And I have to go for stroke volume variation. It is nothing but a dynamic parameter of hemodynamic monitoring. And for this, you have to have the patient on mechanical ventilator with no spontaneous breaths. Okay. So first I'll set one infusion rate. I'll see the stroke volume variation. If this is less than 10%, then I have to decrease the infusion rate. If it is greater than 10%, I have to maintain the same infusion rate. So this will be my goal directed fluid therapy based on SVP. And coming to blood and blood products, we'll be giving this based on the results of TEC. And the blood will be ideally leukodepleted. Microfiltration of the transfused blood have to be done because this is a massive transfusion, and auto transfusion can be done by cell saver, which we have already seen in the equipment part. So what will be our targets is packed RBC will be giving to increase the HB, and our target will be 7 to 9 grams. For FFPs, we'll be targeting INR that will be around 2 to 3, and fibrinogen levels should be greater than 100 mg per ml, and the platelet count should be minimum greater than 50,000, right? So let us see difference between FFPs and cryoprecipitate. FFPs, the volume will be 250 to 300 ml, and cryoprecipitate is 10 to 20 ml, and it contains fibrinogen. FFPs contain fibrinogen of 700 to 800 mg, while cryoprecipitate contains 150 to 250 mg of fibrinogen. FFPs contain all the clotting factors, whereas cryoprecipitate has factor 8, 13 and von Willebrand factor. Okay. So coming to serious complications, obviously there will be hypotension. And for that, I can go for veno-venous bypass. But there will be bypass related complications. And if I'm going for liver transplant without a bypass, I have to see adequate filling before clamping. But that shouldn't be overfilling. Again, it will lead to congestion. Okay? That congestion will lead to graft dysfunction. So during reperfusion, we'll have hyperkalemia, right? Again, arrhythmias might be there, and there may be bradycardia. If it is short-lived, it's okay. If it is prolonged, the patient might land into asystole. Hypotension also, if it is short-lived, and if we correct it immediately, it's okay. Otherwise, the patient might go into multisystemic failure. Okay. So we'll be treating accordingly with calcium, atropine, vasopressors, or fluid. Apart from hypotension and electrolyte disturbances and arrhythmias, there might be pulmonary edema, pulmonary arterial hypertension, air embolism in these patients. Okay. Coming to renal complications, if there is prolonged clamping, or if the patient is already having a pre-existing renal failure, that gets aggravated and the patient might land into renal failure. And not only this, the drugs which we give post-operatively also add on to this renal failure. So we'll be treating with low dose dopamine, mannitol, furosemide. The main aim, we have to maintain the urine output. In the first stage, in the dissection phase, we are maintaining a low CVP, right? But that shouldn't compromise your urine output or MAP. Coming to metabolic complications, there will be metabolic acidosis, right? And we have to maintain a modest hyperventilation, and we have to definitely maintain the cardiac output. We have to prevent hypothermia because it worsens the coagulopathy, causes acidosis, and impair organ function. So other complications might be hyponatremia, hypocalcemia, hyperkalemia. This we have already seen, right? And increased PT due to release of heparin-like substances that will be treated with protamine, and there will be hyperfibrinolysis. So we'll be giving tranexamic acid. Coming to CNS, we should definitely maintain cerebral perfusion pressure. We have to go for a head and elevation, mild hypothermia, mild hypocardia, and maintain MAP. Okay. So if we keep the head and elevation, the arterial pressure transducer will be zeroed at the level of external auditory meters for measuring the cerebral perfusion pressure. So again, intra-op investigations, depending on the complications we'll be having electrolyte disturbances. So we'll go for electrolytes. We'll be having bleeding. So we'll go for hematocrit, platelet count, and coagulation monitoring. TEG will be having decreased gluconeogenesis. So there will be hypoglycemia. So we have to check for blood glucose. There will be metabolic derangement. So we'll go for ABG to check for any acidosis. And the main things are the WBC count. If it is increased in post reperfusion period, that means it is graft rejection. And if the serum lactate doesn't reach the baseline or doesn't go in a downtrend, again that means there is graft dysfunction. Okay. So post-operatively what we will do? We have to go for an elective ventilation, immunosuppressive therapy, and the patient should be isolated because it's more prone for infections right now. And extubation will be planned depending on the hemodynamic stability after 1 to 3 days. And pain management will be multimodal, right? Epidural, IV opioids, IV analgesics based on TSB and renal functioning and regional blocks. Okay. So post-op concerns again, all the multi-organ we have to check. Pre-op we have checked all the organs, right? Post-op also will check all the organs. First, hemodynamic issues, again there might be any hypotension, arrhythmias, hepatopulmonary hypertension, and hypertension is not that common. Okay, pulmonary issues, it is a prolonged surgery, or the patient is already having atelectasis, so there may be atelectasis, pleural effusion, pneumonia. Okay. Coming to renal and electrolyte issues, there might be renal dysfunction and all the electrolyte disturbances. Okay. Neurological issues, if the patient is having hepatic encephalopathy before, he might have now also, right? Hepatic encephalopathy, electrolyte disturbances, and idiosyncratic effects of immunosuppressants that we give postoperatively. GI issues for any post-op patient, there might be stress ulcers, and the patient is a liver disease patient, so there might be ascites, and we have to go for high protein content as soon as possible. And we have to go for feeding, enteral or parental feed. Hematological bleeding and thrombosis will be our major issues, so we have to go for tech even post-operatively. And coming to finally the surgery proper, graft issues might be there, sepsis might be there, pain will be there. We have to see the liver functioning also after grafting. So this is about liver transplant in the patient. Now, what about the donor? The donor hepatectomy surgery is almost like a routine surgery. So we'll be doing PAC, general examination, we'll see the labs, we'll go for pre-op preparation, giving anxiolytics, PPIs, and aspiration prophylaxis. We have to keep blood products ready, and our plan of anesthesia will be GA with regional analgesia. So the monitoring part, as usual, the main thing is we have to decrease blood loss. Okay. So we'll be maintaining low CVP. Okay. And the fluid management will be goal directed, or we can ask the surgeon about the IVC status, and depending on that, we can give the fluid. And we have to prevent hypothermia intraoperatively. We have to prevent DVT. We have to prepare ourselves for massive hemorrhage in even in donor hepatectomy. Okay. So introp investigations, depending on the hemorrhage going on, we'll be going for HP, electrolytes, and ABG. If it is going like a normal case, we need not go for investigations intraoperatively. So post-operatively, we'll go for on-table extubation, multimodal pain management. Early ambulation is very much necessary. We have to give thromboprophylaxis for these patients, and we have to check for any bleeding and coagulation abnormalities post-operatively. So this is about overall. The main thing about the liver functioning we have to check, and we have to check serum lactate levels and the surgical related complications like bile leak, infections, and the liver failure. Okay. So this is about donor hepatectomy. So mainly about hemorrhage and the liver and surgical related complications we have to take care. Okay.